Much, and I'll invite our next speaker. I think we'll go to Dr. Faisal first for his talk. If you have any quick questions, we can actually ask. And any quick questions, we can take one or two questions. All right, Dr. Faisal, please.
So very good afternoon, everybody. I thank AIOS and Professor Panda for inviting to this wonderful IC. So I will start my talk as how to identify a failing blebs. So even the time of mushrooming of multiple mixed surgeries, trabeculectomy with MMC is still the gold standard. We all like to prefer trabeculectomy as a first-line procedure in most of the cases. So even in a well-experienced man, the long-term success of the primary trabectomy is ranging from 57 to 90%. So what we would like to get an ideal bleb that is like moderate height, normal conjunctival vascularity, and posteriorly flowing diffuse bleb, and no leak at surgical incision, well-formed AC and target IOP. But often we get pictures like that, maybe scarred or cystomant or thin cystic leaky avascular bleb. So how to identify before going to this stage? So bleb failure can happen at any stage of after the surgery, maybe very early stage itself, or in the early, like within 1 week to 2 weeks, or in the intermediate, maybe after 2 weeks to 6 weeks, maybe late in months to years. So in the very early stage, one should have signs of the excessive hyperemia, very low or hypotony, and the excessive vascularization. These have the major signs in the very early stages. So the excessive hyperemia means there is more vascularity, and the more what happens with more vascularity, it will inhibit more of the fibroblasts and more of the inflammatory cytokine, which leads to early fibrosis and failure. And one should find out the various causes for the early low IOP of hypotony, because the hypotony lead to less flow through the subconjunctival space, causes mechanical adhesion or early wound healing. Then further on, if you even increase the IOP, the bleb won't lift it up. So one should roll out the bleb leaks or any other alternative pathway for echoes or any conjunctival wound leak or at the surgical margin, or at inadvertent conjunctival injury. Or any other, in this page there is a conjunctival leak here and suprachoroidal, there is a serous choroidal also. One should build up the IOP as early as possible to a normal level. Then what will happen to the early rise in IOPs are already discussed, but if the IOP rises, that causes the mechanical as well as the and also what are the reasons for an early built-in IOP. So one can have to look at the iris plugging or look at this bleb, though there is much highly vascularized bleb, even in there is a encystment or the fibrosis started here within a week itself. So one should find out what are the reasons for high IOP, then treat the IOP and lower the IOP to a normal level. So, sir, already told high IOP initial 1 to 2 weeks, one should be taking care of with anti-glaucoma medication or any treatable pathology, should treat with maybe go for surgical to relieve the iris block, or maybe node 5FU or bleb needling. So next sign is the small bleb. You should assess the bleb size. The small bleb may be due to restricted posterior flow, and careful assessment of the scleral flap often forgot here, because in the early stage one won't expect the fibrosis around the scleral flap. So even if the conjunctiva is loose or mobile, one should slightly gently palpate the periscleral area with the patient's lid itself. So if you don't get a smooth feel or hard wooden feel, then you should think about there is fibrosis started around the flap area, that is around the flap margin. So then the next is I already told about the other features like encapsulated bleb. The first picture I already told, the first week itself the encapsulation has started. In the second picture there is 2 weeks post-operatively, there is encapsulation already started. So you have to think about treat these causes along with the reduction in IOP if the IOP has raised up. So then encapsulation can happen later also, in the intermediate to late phase also. Like this case, this around 6 weeks, this is also around 6 to 8 week time, this encapsulation has started and the IOP started rising slowly. So these are the major signs like IOP, The fluctuations in the very low IOP or high IOP postoperatively, or the hyperemia, vascularity, and the bleb size, and the cyst formations. One can have this like ring of steel formation because the fluid confined into the particular very localized area. Then there is addition between the conjunctiva and sclera peripheral to that. That's lead to a ring of steel appearance. All the fluids are going to here only. So one need to tackle this reason as early as possible to get a outcome later on. Very late sign may be like flat bleb or like a scarred bleb like this. One should have to tackle these changes. One to identify very early these changes. So, and very thin and avascular bleb is also risk for failures because this indicate that there is avascularity necrosis and the poor functioning of the bleb also. So there are imaging techniques also one can do like UBM or ASOCT. In a normal functioning bleb like a thick, hyporeflective with multiple intrastromal cysts, whereas a non-functioning bleb look like more hyperreflective with low or without any microcystic changes in the stroma. So early detection and timely intervention is important to identify the failure, and various signs I already described, and to how to tackle these according to these signs, how to treat why the bleb has going to fail, or to treat at the time.
Thank you, Dr. Faisal. Any questions to Dr. Faisal, because he will be leaving the hall. Any questions? I think what Dr. Faisal has tried to show is that blebs can fail in very different ways and at different times. We are mostly concerned about the immediate post-operative failure because we want the trap to succeed, and if the trabeculectomy works for the first 3 months or so, then the chances are that it's going to work later also. But that's not always true because these blebs keep on evolving. In fact, trabeculectomy blebs never heal. We say the wound heals, but if you look at it, the trabecular blebs, they actually never heal in that sense because something is always going on there. The fibrosis, which has at first there is a vascularization, inflammation, then you have then the scar is formed, and then there should be a remodeling of the scar. So the remodeling keeps on happening, and that that is always there. So sometimes you see the blebs fail late, and sometimes we also see in the late hypertony can also happen. This, for some reason the fibrous tissue becomes thinner or apoptotic because the apoptosis goes away, and the trabeculectomy, which was functioning normally, actually start functioning like more. Sometimes that also happens, but commonly there's a fibrosis which leads to increase in IOP. In the initial period, like Dr. Faisal mentioned, I think the important signs are that the inflammation, the vascularization of the bleb height, and the IOP. So they actually give you a good clue that you need to do something. You need to modulate these blebs so that they function better. And normally we are using mitomycin C, and we expect that the blebs should be pale looking or avascular, and if you see a little pale, like I think when I showed you those pictures, the B bleb that was actually looking less vascular at 7 days and even later, and that was also a little pale in the center. So we we have that understanding that bleb should do better, but not always. What happens is that the pale bleb actually indicates that there's a less of vascularity there. So that means there's a relative ischemia there. So if you have a bleb which is becoming pale early in your post-operative period, that means that bleb is actually ischemic. So if you have bleb which is ischemic, that will produce VEGF-like, and that will induce vascularization. But because now we have treated that bleb with the mitomycin C, the vessels cannot really grow into that area. So the vessels, they will grow in the periphery. And when they grow in the periphery, they'll produce a fibrovascular elements, they lay down the fibrovascular bundles in the periphery of that blister which is forming. And that is what I think Dr. Faisal referred to as the ring of steel, and we also call this a ring of steel is formed. So how the ring of steel is formed? That's formed because the vessels cannot grow to the central area because there's a mitomycin C induced inhibition there, but there's a more production of the VEGF, so more vessels are coming in, so they are stopping at some point, and that point becomes your barrier ring of steel. So that's how these blebs fail. Thank you, Faisal.